So tonight's lesson, the three chapters we're covering start at the head, and we're going to work our way from the head down through the abdomen. So we'll get from these chapters down through basically to about the waistline. So we're doing head, face, neck, chest, and abdomen as it relates to trauma. And we'll talk about what's going on in those areas, what you guys are looking for, what kind of injuries there are, and then what we can do about them. So at the A level treatments for these types of things, chapter 37 is first. So as always, there's a little A&P section, so it goes over the brain, parts of the brain, into the spinal column at the base of the brain. It talks about some of the facial features and of course the eye sockets and the eyes again. We just hit those in the medical section as we were finishing that up. So you should have hopefully some familiarity still with the eye stuff. And then we'll get into the assessment of the head. So when we're doing our trauma assessment, what are we looking for as far as assessing and examining the head?
Crepitus.
Crepitus. So what does that mean?
You're looking for shearing and cracking of the bones.
Okay. So if we're palpating, we can feel if those bones are cracked or destroyed. We can hear and feel that movement between the cracks with our hands. There may be some indentions there, some depressions. So if they had a blunt force trauma to the skull, it could have fractured it. It also could have depressed that bone so that when we kind of feel along, we may feel a dent or a little dip in there. And those types of things are bad. With relation to the scalp, any injuries related to the scalp, what should we expect?
Bleeding.
How much?
Excessive amount of bleeding.
Yeah, the scalp is going to bleed pretty good. So we should be prepared for quite a bit of bleeding. However, that is usually controlled fairly easily and quickly. If you get like lacerations to the scalp, they may need stitches. A lot of it is kind of hard to find if people have a lot of hair. We may have to kind of work our way through that to get to where the actual injury is. And of course, when they go to fix it, they may have to do a little cutting or shaving. They got a few options for fixing these facial and scalp lacerations now. They can use some glue. They've always had stitches. Now they got staples and they also have glue. So just depends on the injury and the doctors and that sort of thing. But all right, so worry about the scalp. What else are we looking for? So we got some crepitus with the skull, fractures there. What else are we going to be checking out?
Hematomas.
Okay. So where do we expect to find those? Any particular places?
The forehead or the back of the head.
Yeah, the forehead's always a good one, right? Get that nice goose egg up there on the forehead. Back of the head, if they basically fall forward or fall backwards, those are the places. they do occur on the sides of the head, although probably less common, unless it's like a side impact thing. If they're in a car and kind of side impact and hit the side of the car, maybe. But, typically a lot of people, when they fall, they either fall forwards or backwards. And so the front or the back is more likely to be the location for those things. All right, keep going.
Lacerations.
Okay. Again, on the head, these things are going to bleed a lot. So just be prepared for lacerations on the head and the face. They will come with quite a bit of bleeding, but usually it's easily controlled. And then once it stops, you can get a good idea of what the injury is. Let's talk about what happens to the brain during these injuries. If you have a head injury, what's happening with the brain?
Being whipped around in there.
What's that?
It's being whipped around in there. Was it
Okay.
like recoup or some kind of, I forget what it's called. There's a word for it. I mean,
It can also cause the brain to swell.
Okay. So if there's if there is an injury, some kind of traumatic. What's that?
What is it, like poop, counter poop?
Yeah. If there is an injury to the head, depending on what type of injury it is, if it's like a whiplash type of thing, or if there's like a blunt trauma type of injury, the brain is encased inside of the skull, and you're going to have a little bit of motion where that brain is kind of going to rattle around in there. So it's got some fluid in there that helps it kind of shock absorb. But with these sudden movements and impacts, that fluid can't absorb that much shock. So then the brain is kind of rattling around. So it's going to hit at some point on some side of that skull. And then you're going to have an injury point there, depending on the force. You may have damage to the skull in the form of a fracture or a multi fracture type of thing. You could have that depression we were talking about, or different other types of things. But the end result is going to be from that trauma that the brain will most likely start to swell. And when it's swelling, unless it becomes an open fracture where that fluid is being released externally, then it's a closed fracture, and the brain is in a limited amount of space. And as it starts to swell, that the space doesn't grow. So the skull is fixed, it doesn't expand, but the brain starts to swell and there's nowhere for it to go. So that pressure is going to cause some problems for us. So what kind of problems are we going to be looking at and facing?
Altered mental status.
Okay.
Increases in ICP.
Yeah, that's what's happening here. When this brain swells, then the intracranial pressure is going to increase. As a result of that, the body is going to start to make some compensations because of that increased pressure. So as this ICP goes up, which is the increase in this pressure, what's the body going to do? What kind of compensations is it going to start to make?
Since the pressure in the head is increasing, the body naturally tries to increase the blood pressure to overcome the pressure in the brain to help perfuse the tissues in the brain.
Right. So how is it going to increase blood pressure?
Got me stumped there. I'm pretty sure with increased ICP, it affects the heart rate. I can't remember if it's slower or faster.
I think the heart rate increases.
Initially, it will. Initially, it will, but there will be a point where the blood pressure will actually be increasing while the heart rate is slowing, and that is what's known as Cushing's reflex. So when you get to that point, you'll see that they'll actually have a very high blood pressure but a low heart rate, because typically those are going to increase together. Heart rate's going to increase, blood pressure's going to increase, and so those are going to go up together. When they start to go in opposite directions, then that's what we refer to as Cushing's reflex. But in the interim, when the blood pressure is increasing because of this ICP, we're looking at vessel constriction, the contractility there, and this is all going to be done by hormone release. So the body is going to release these hormones that are going to help strengthen these vessels, contract them, give them that force to increase the pressure. So what's going to happen as the swelling continues, the blood pressure continues to rise to overcome that? What's going to happen to the brain?
Can you re-ask that question?
As the brain continues to swell and the blood pressure continues to rise to overcome that swelling, what is eventually going to happen to the brain?
It starts to push out of the hole in the bottom of the skull because something's got to give.
Something's got to give eventually. So what's this called when that happens?
I forget the word for it. I remember reading it.
All right. That's when that's when we have brain herniation.
Yeah.
This thing will herniate, just like a hernia in the abdomen. The brain will have a hernia, which is not good. Indications for brain herniation, what does that look like?
Here it says a common indication of increased ICP and impeding brain herniation is unequal pupils.
Right. So if we've got ICP and we start to have other signs like unequal pupils, this is also a good time to have altered mental status, those types of things, and you may actually find some extremity function deficits. This is when this is starting to happen. So what is the fix for this?
Surgery. Drill a hole in the skull.
Yeah, that'd be the quickest way. They actually have, they have to get relief on this pressure, and so that is what the neurosurgeons are going to do. They're going to drill a hole and relieve that pressure until they can figure out where the swelling is coming from and get some things in place that can reverse that, so they can reduce the pressure, and they've got to basically heal the brain and get the swelling down, and then they can go back in there and fix the hole that they made. So for us, obviously we can't drill holes in people's heads, right? They frown upon that at this level. Do we have any options for reducing ICP? No one know of anything we can do for these folks?
I'm not seeing anything in the book. All it's saying is like if they have other traumatic injuries and their blood pressure starts to drop, to give them IV fluids to maintain perfusion.
Right. And we really don't have a really don't have a treatment at this level for reducing ICP. There's no medications that we carry at the A level that are going to do it. We don't have the ability to drill holes in their head to relieve that pressure. So this is going to be a situation where we may recognize that they're having increased cranial pressure, but there's not a whole lot that we can do about it except get them to the neurosurgeons that they need. So all of our supportive care stuff is going to come into place with the trauma event. So IVs definitely warranted. Trauma assessment is definitely warranted. Trending vital signs are good. And then checking all of these things that we would be looking for, which would be altered mental status, unequal pupils, injury to the head that we could find and note. In the late stages of this herniation, you may see the patient actually doing some posturing and things like that, because the brain is being affected at that point with the motor function. So they'll probably lose consciousness at some point. They may lose functionality in extremities, and then you may actually see some posturing and stuff like that. And those points, you're probably going to start to notice breathing issues. So you'll have some vital sign discrepancies, so to speak. Things will be out of whack, meaning the blood pressure may be high, your pulse may be low, but then you get irregular breathing patterns and things like that. So you can see stuff going all kinds of crazy.
I had a patient today. She was in a car crash, and she presented. The only presentation she had was neck pain. And then we got her in the ambulance, and we took her blood pressure. It was like 190 over 100.
There you go.
And I don't know if that was anything that had to do with increased ICP, because she didn't have altered mental status. All she said was neck pain. And
Right.
then turns out when she got to the hospital, she had an unstable C2 fracture and a slow brain bleed.
So there you go. That is an indication. So that blood pressure was probably an indication of early ICP, but it was early. So you don't get all of these other things yet. Remember, this is a process. So as long as there's space in there in the skull, as long as there's space, then everything is fine. It's when the space is all taken up, but the brain continues to swell. And as that brain bleed continues, it's going to take up all the space, right? And then it's going to put more pressure on the brain. And that's when if that goes unchecked and untreated, then that's when you're going to start to see these other things coming up. So not necessarily right off are you going to see these, but they could start presenting in a short time. It just depends on how fast, things are leaking, things are bleeding, and that space is getting taken up. The space is either going to get taken up by brain swelling or by bleeding, and then the pressure is going to start to change on the brain. So was that the wreck at the school?
Yeah.
Okay.
She was the only person that got hurt. Everyone else was fine.
Right. Well, it sounds like her injuries are pretty significant, though.
Yeah, and she presented like she was so calm. She didn't even want to go to the hospital, and we convinced her to go. And then when we get in the back of the ambulance, as calm as can be, or I asked her what her pain was on a scale of 1 to 10, and as calm as could be, she was like, "Yeah, I would say it's probably about a 10."
Oh boy. But the problem with those folks is those are the ones that if they don't go and get checked out and get all these scans done, if they refuse at the scene and go home, they'll be the ones, 6 or 8 hours later that we're getting called to at home because they are like posturing or unconscious or something like that because of now all of this swelling and space being taken up. ICP is going to be through the roof. Blood pressure is probably going to be sky high, and then you would see all of this stuff that we're talking about now. So those are the people.
Yeah.
Those are the ones. You go to Rex and the wreck doesn't seem that significant. They act like they're fine, but lo and behold, they've got a brain bleed that's pretty slow, and over, a few hours or a day, they're the ones falling out. And that's what they find when they do these scans, is that, their head's full of blood because it's been bleeding since the accident. All right. So that's the head injury part, the brain part, with the ICP, and that's going to be a big thing for us. Traumatic brain injury now is a big thing in a lot of different areas. You'll see traumatic brain injury being talked about in the military. It's being talked about in professional football and a bunch of other areas, NASCAR racing, different things like that. They're looking at all of these, bumps and bangs and impacts, and what's happening to the brain is basically that it's rattling around in their head like a pinball. And the military's dealing with it with all of these explosions and concussions that they're being hit with. Football's doing it with these high impact tackles and things like that. So they're trying to improve the safety of helmets and do all that. NASCAR went into all this safety stuff with restraints and those types of things because their drivers are getting killed in wrecks. So these traumatic brain injuries they're real. They're a thing. It's long term. It's chronic injury to the brain. It's happening over and over and over, and the damage is being done in there. And these people are having issues with memory. They're having issues with motor function, that sort of stuff. And so it is something that's being studied quite a bit. Although from our world, it doesn't really change anything. We go to the traumatic event and our treatments are pretty much set. So, we don't really have anything differently to do, but this is just going to be long-term stuff. This is what they're finding out long-term effects are from these injuries. And it's just repeated injuries that are occurring. So be aware of these things. If sometimes a little history goes a long way, and some people are more susceptible to traumatic brain injury because of their past and what they've been doing for work and that sort of stuff. Concussions now, we've changed our stance on concussions. So if you knew anything about concussions years ago, if you were suspected of having one, they didn't want you to go to sleep. They thought if you went to sleep, you wouldn't wake up. So they tried to keep you awake. And now they've found out that the way the brain heals is when you sleep. So they want you to sleep as much as you can. If you have a concussion now, the doctors are going to tell you to sleep. And they're going to tell you to rest and sleep, and that's going to be the treatment for the concussions. So be mindful of that.
So I have a question about that.
Okay.
So what about the people that do go to sleep and don't wake up? Is it just, it would happen if they had stayed awake? Because wasn't there a doctor whose son, he got into, I forget exactly, I think it was like a sports injury or something, and went to sleep and then didn't wake up.
And the only thing that I could suggest in that is that this is where those scans are so important, because there's probably a brain bleed in there. There's something happening that's probably causing that ICP to increase, and then you don't have you have those bad things.
So regardless if he had gone to sleep or not, he probably would have.
Right.
It probably would have killed him regardless. Okay.
Yeah, the actions would have happened at some point regardless. If there's some kind of bleed in there or something, once the pressure gets high enough and that brain herniates, then you're going to see all of those negative effects that we talked about earlier with the altered mental status, the unconsciousness, the I haven't said seizures because I'm not sure it's actually a seizure, as it is more of like the posturing stuff. So I think it's more posturing than seizure. But you're going to see those types of responses from that. With the technology today and the head injury, if you go into, an ER with a head injury, especially from like a football game or a motor vehicle accident or something like that, for them to not run a CT on you is almost criminal of the doctors to start with. So hopefully they could pick that up and find it. And if they say, well, that's blank, we're not seeing any blood there, then, they can go into the concussion world and say, you probably got a concussion. And then that's when they're going to tell you, go home and sleep, rest, 2 or 3 days of sleep and rest. And, you get your concussion protocol, you're going to get reevaluated in a few days. And they're going to check you out to see if your brain is doing better, healing up, and you don't have any memory issues and that type of thing. All of your functionalities are there. But for the ones that go to sleep and don't wake up, then I suspect that there is a significant injury that just didn't get diagnosed or got overlooked or missed or something. All right, so you got your concussions. There is a cerebral contusion that your book talks about, with your brain bouncing around, and that's Crystal's coup and counter coup injuries there. And then you get a nice long list of traumatic brain injury signs and symptoms. So if you're in your book, on the bottom of 853, there's a nice list of signs and symptoms if you're looking for these types of things for TBIs. So the most prominent one with me is nausea and vomiting. So if somebody was injured, especially if they have a head injury, and then they start to have nausea and start vomiting, then that's a pretty clear indication in most cases that there's some kind of brain injury. All of the others you can put together and see how those come about with your patients, but you'll see that you'll see these things come about. So altered mental status is always going to lead you down the road, but if they're awake and talking and all of a sudden they just start to throw up, then you should suspect that they've got some kind of head injury that from that event that they were just in. So if it's a football game or a car accident or they fell from a height and hit their head in some manner, then you should suspect that there's some kind of head injury there. All right. So your book also talks a little bit about intracranial hemorrhaging. So when it starts to have that bleeding in the brain, it's going to get you a little bit into that and how the pressure is going to change and where that blood is going to go, because it doesn't have much to go. So when we're doing our assessment on these folks, trauma assessment, we're going to get through those ABCs and life threats, and then we're going to do a more detailed look at them as a whole. And we take that, typically we like to take that systematic approach of starting at the head and working our way down the body. And most people alter this in some form or fashion as they go down the body, but which is okay. as long as you get everything assessed and everything covered. So if we start at the head on this more detailed look of the trauma patient, and it'll be different depending on whether or not they're awake or unconscious, because if they're awake, we can talk to them and ask them questions. And if not, then we're just looking at what we can find because they don't have any complaints. So take me through how you would do this assessment and what you would be looking for and where you would be looking. Just with the head for now. We're going to work our way through the chest and abdomen in the next 2 chapters. But for this chapter, let's just look at the head and take me through the process of how you're going to do the assessment for the trauma patient.
So if we're gonna do the assessment on the trauma patient with the head, is it a fall cliff or it doesn't matter?
It doesn't matter. It could be a fall or a wreck or whatever you want it to be.
All right, so first, go ahead.
So just whatever it is and whatever you want it to be, just take me through what your initial assessment would look like, and what you would be checking for, how would you be checking for it, what are you expecting or looking for, those types of things.
Okay, well, if I had to do a head assessment, my initial assessment, first I'm gonna make sure the scene's safe and have on my PPE. I'm gonna look at the outer and check the airway, make sure they can talk to me and make sure they're breathing.
Right.
I'm going to have somebody do C-spine if it's a fall or a wreck. Get somebody to hold C-spine, and we're gonna check the neck. But I'm gonna start my assessment. I'm gonna start with my fingers. I'm gonna hold the head. If I'm facing the head, I'm gonna start from the top of the head, and I'm gonna walk my fingers through and look for abrasions. I'm gonna look for lacerations and avulsions and bleeding. Control the bleeding first.
Right.
But I'm feeling for crepitus or any broken bones. Seeing if they have any open fractures or anything that's punctured it, penetrating objects. And that's how I would assess the head as somebody is holding C-spine.
Okay, so you're going to be up there feeling around the top of the head, the back of the head, all around their hair and stuff, and working through that. Those types of things you're feeling for, crepitus, depressions, looking for bleeding, seeing if there's lacerations or whatever type it is, if you do find bleeding. And then as you work your way down towards the neck, what else are you going to be looking for on the rest of the head?
I'm gonna be looking for posturing or any signs of pain, and watching their face for grimaces.
Okay, so you're gonna be looking at their face to see if there's any change in that. Posturing. Are you gonna check anything? What other things are you gonna check on their head?
What other hematoma? Look for hematomas.
Okay, so you're gonna look for for bruising, for swelling, for all of those things, to see if you have those.
Yes.
Are you going to look in their ears?
Oh yeah. Look for drainage or clear fluid
Okay.
when
What
I get
else?
to the ear and blood.
All right. What else are you going to check for?
Brain matter.
Okay. If you don't find any of that stuff, then what are you going to do?
Keep on with my assessment.
Where are you going next?
To the face.
What are you looking for? What are you checking?
Looking for raccoon eyes.
Okay.
Raccoon eyes, which is pooling of blood around the eyes. I'm gonna
Mm-hmm.
check the nose and the sinus area, see if any crepitus is in that area. Just in case we have to help with the airway. We'll know whether we got broken bones in the face. Looking for missing teeth and things like that.
Okay. Sounds good. What about the eyes? Do you want to check the
I'll be
eyes?
for our pupils. We'll turn the lights down and check the pupils and see if they're equal and reactive. See if they're reacting to the light. Because if they're not reacting, we really have a problem. Or if they're unequal, that could be a TBI or causing of ICP from ICP.
Okay.
And then the redness of the eyes, make sure no blood vessels got busted in the eye.
Okay. So we've checked the eyes, we've checked the ears, we've checked the nose, looked in their mouth, see if they bit their tongue, got any teeth missing, anything like that. Look around for cuts, bruises, bumps, swelling, that sort of stuff. And then we should be about at the chin or jaw area as we're working our way down, right?
Yes.
Anything you want to check in there?
Oh yeah.
Chin or
You
jaw
talking about
area?
where you at? Yeah, we can check for breakage in the maxilla
Mm-hmm.
and the mandible. See
Okay.
if they're not dislocated or anything.
Okay. What about in the neck area?
We're checking the C-spine. Run your fingers down the pain or swelling, bruising.
What else in the neck? What are in the back? We're looking at the C-spine, that sort of thing. We're looking for any kind of deformities or displacements, swelling, stuff like that. But what about in the front? Anything in the front of the neck you want to check for?
Yeah, I'm checking for JVD
Okay.
and this what is this extension or distension, and you can check the airway, the Adam's apple, make sure all that's intact.
Okay. Intact, in line, those types of things.
Mm-hmm.
Sounds good. And that should get us down to about the shoulders, right?
Yes.
So remember when you're checking these things, that trauma acronym DCAP BTLS, those are the types of things that you're looking for. And so as you go through this hands-on assessment where you're doing a lot of palpating, you're doing a lot of looking at this patient, and if they're conscious, you're probably doing a lot of talking to them, trying to get some responses out of them about anything that hurts or any pain they may have, or you may find some pain that they're not realizing yet. Maybe they're focusing on something else. They may have one injury, and as you assess them, you may find another that their mind just isn't focused on because the other one hurts so bad. So so make sure that you're doing a thorough assessment of these folks and that you're checking for these things. All of these DCAP BTLS things, they're all documented injuries that you have found. So everything that you find, you should document when you do your assessment documentation. Make sure that you're writing down all of these locations, what type of injury it was, you know, if they've got abrasions on their elbows or knees, that sort of thing. If there's any open wounds, punctures, things like that, what caused it, where it's located. The biggest thing on this is where it's located on the body and what type of thing it is you found. So bruising versus the goose egg, versus a puncture wound, a laceration, or an abrasion, those types of things. Make sure you're documenting them accurately as to far as what they are and where they're located. If it is a laceration, usually they like to have a length that goes along with it. For puncture wounds, it's a size. They like for you to clarify these things and describe them. So typically they would like for you to estimate lengths and sizes and that type of stuff. So if you can be as descriptive as possible in your documentation, then that would be most helpful, especially to your pass on folks as well as to your QA folks and in-house people that are looking at these reports. All right. Any questions about chapter 37? You guys got any questions about the head? Any injuries with the head or the face and the neck? That gets us down to about the shoulders area. So we're going to get into chapter 38, which is going to be the chest in just a second. All right. I'm going to, just so you guys know, Caitlin is here with us for a minute. And if you guys would give me just a second to talk with her, I'm going to put you all back out in the waiting room for a second, and then I'll bring you back in just a minute, okay? Hey, how are you? You're on mute, ding dong.
I was letting you know you were still recording.
Yeah, I know, I'm still recording. There you go.
All right.
Have fun.
Hey, everybody, can you hear me? Hello, hello.
I can hear you.
How about you, Derek? How about you, Crystal?
I'm fine. I'm here.
Good.
Okay. All right. So chapter 38, let me make sure. Chapter 38, we start covering our thoracic trauma emergencies. So of course, to treat that or do an assessment, we need to know what encases our thoracic cavity. So Crystal, you know it's gonna call on you. What is in our thoracic cavity? What would you expect to assess? All right, Derek. Can anybody hear me? Hello?
I hear you.
Crystal.
Yeah. Sorry, it muted.
Can you tell me what is in our thoracic cavity?
Thoracic. Is that like your stomach and all that? Thorax.
So our
Your heart,
thoracic
lungs,
cavity, yep,
heart,
our
lungs.
heart, our lungs, your thoracic cavity is basically, it's enclosed by your rib cage. So everything that's underneath your rib cage. So that encases like our pulmonary system, our heart, so part of your esophagus. And that remember your diaphragm at that point is what separates the cavity from your thoracic cavity to your abdominal cavity. So when you're thinking of your thoracic cavity, it's not your entire front portion of your body. It's actually separated into two. So our thoracic cavity definitely carries some important parts that we need to worry about during our trauma assessment. So we were working our way down and we were coming down, and I think you had got to any like trachea deviation. So Crystal, walk our way down after looking at any trachea deviation through an assessment of our thoracic cavity.
Are you talking to me?
Yes.
Okay, hold on one second. So we won't look for any bruising or anything.
Okay.
Any swelling? I missed like the first part of everything that you said because I was muted, but you were muted also. Like I couldn't hear y'all say anything. I just staring at a blank screen.
We're doing our trauma assessment of the thoracic cavity.
Okay, so I mean, you look for the same thing you do with anywhere else, the DCAT, BTLS, any kind of deformities, contusions. I mean, do you want me to go through all that?
Yes.
Okay, deformities, contusions, abrasions, penetrations, burns, tenderness, lacerations, and swelling. And you listen to lung sounds.
Lung sounds, perfect. Okay, so lung sounds are definitely important during this trauma assessment of the thoracic cavity. So Derek,
Listen to heart sounds too.
Yes, heart sounds, absolutely. So lung sounds, what are some lung sounds that of course we hear when listening that are out of the norm?
Strider,
Absence of lung sounds on one side.
What could that indicate?
And pneumothorax.
Absolutely. Are there any other signs and symptoms that we can have for pneumothorax?
JVD.
JVD, okay. Yeah,
And is the flail chest? That's for like a broken rib, right? It's like unequal rise and fall, right?
you can have the unequal rise and fall of the chest, yes. One of the foremost things that you're going to have with a pneumothorax is your patient is going to tell you that they are having trouble breathing. And basically your interventions, of course, if somebody has trouble breathing, what are we looking for? Low O2 saturations, right? Any of that discoloration, cyanosis of the skin. We're looking for those typical signs that we see. But when you're doing these interventions and say that you're putting them on the high flow O2, you're looking at their airway, you're repositioning. If they're still having trouble breathing, make sure that you look for those signs of the pneumothorax. Because what's going to happen if we don't treat them?
It's gonna get
That
worse.
pressure is going to increase. It's going to get worse and worse and worse. And what happens when that pneumothorax gets worse? What does it start to affect?
Your heart rate.
Yeah,
Circulation.
Yep, absolutely. It's putting pressure on that heart because of all of that air that's getting trapped. So pneumothorax is definitely early notification and diagnosis, because who do you got to notify?
You're asking who are we going to notify?
Yep,
Like
The
the
medic,
hospital.
the medic that's coming to us.
the medic that's coming to you. Yes, absolutely. All right, so when we're talking about lung sounds, we talked about stridor, absent lung sounds that could possibly be a pneumothorax. What are some other lung sounds?
Wheezing, gurgle.
Wheezing, all right.
What
So
is it? Gurgling.
gurgling, yeah. So gurgling usually indicates what?
Fluid in the upper.
Fluid, all right. So
Okay.
where do we hear wheezing in our lungs? Where does wheezing come from?
Upper or lower.
Okay.
It
So
could be
wheezing is
fine.
typically, when we hear it, that's lower, that's in our bronchioles, right? All right, so when we hear wheezing, what's another word they typically say that goes with wheezing?
Like whistling.
That's more describing it.
Stridor.
That's our upper way.
I don't know what you're looking for.
How about bronchi?
Oh, bronchi and the bronchi, rails
Yep,
and the
there-
tails.
So there we go. Yes, that's what I was getting to. So bronchi, typically when we're listening to lung sounds, it's important not to only identify, but know where we hear them. So like Crystal was just saying, bronchi, you hear in the bronchi. All right, so that's more of typically like mucus, and there's that's causing that obstruction for us to hear that. And then typically the wheezing we hear because there's that constriction. So if we hear bronchi, we could possibly think that there's something going on in that lower airway that's causing that sound to be present. All right, so when we think of our thoracic cavity, we also have our spinal process. How many bones or vertebrae are in our thoracic cavity? Our thoracic spinal process. It's an easy number to remember.
Seven. I don't know.
There's 12.
Oh.
So when we look at
How
this,
is that
we look
easy
at,
to remember, Caitlin?
because you go through your thing, 7, 12, 5, sacrum, and coccyx. It's just easy. So the way
Okay. I'm gonna say a dozen eggs.
So remember though, when we're doing our assessments in our thoracic cavity, to also make sure that we associate that spinal process with it too, because they're connected, right? So we want to make sure that when we are assessing any traumatic injuries to our anterior or posterior, that we also associate with it the circumference. We want to pull that around. So if there's anything that we note in that thoracic thoracic spinal process, when we're walking our ways down, make sure that we associate it going through because they're connected. All right, so abdominal cavities. So abdominal is super important. We all know that, right? What is in our abdominal cavity? We'll start with our right upper quadrant. We know that there's 4 quadrants, right? So Demetria, what's in our right upper quadrant? And remember, this is the patient's right.
In the patient's right upper quadrant, they have the liver, the gallbladder, and part of the intestines.
Okay. So the liver, let's talk about the liver a little bit. What's important to know about the liver?
You asking me?
Yes.
Oh, it's very sensitive and easy to tear.
Okay.
But I don't know anything else that's important about the liver.
Okay. So we know that the liver bleeds a lot, right?
Mhm.
Derek, what else do we know about the liver?
You're gonna want to know if they have any type of disease of the liver
Yeah.
that makes it weaker or not as adequate working.
Okay. So what does our liver do?
I know it's a filter.
Right.
Doesn't
So
it filter
that
out
filter is
toxins?
not working. What happens to all that bad stuff it's supposed to filter for us?
All the toxins are released into the body.
Okay. And then what happens to our skin?
Yellow. Jaundice.
It turns yellow. That's that bilirubin that is backing up and causing the yellowness of our skin. So if we see those in our trauma patients, we can start to think that maybe they already have some type of disease with the liver. Sometimes it can be hereditary, sometimes it could be due to lifestyle. But that helps because we know that if we think that there's something already going on with that liver prior to any type of trauma, we can say, hey, a little bit more injury because this thing probably wasn't as healthy to begin with as it could have been. Also, our liver is pretty big, right?
I mean, I guess you can live with part of a liver, can't you? And that's the only organ that you can, like, take part of it away and,
Yes.
like, take the disease part away and keep the rest of it, and you still live.
Right. Is there anything else important that's in our right upper quadrant?
The gallbladder and the part of the intestines, the large and the small.
Okay. All right. How about our left upper quadrant?
And stomach and the pancreas.
Okay. We got something else over there that likes to bleed a lot too.
The spleen.
Spleen. So let's say that we go to a patient who was in a motor vehicle accident, and let's say they were unrestrained. We all know what I mean when I say unrestrained. It means they were not wearing their seatbelt, and that his chief complaint is abdominal pain. Okay. So let's say that he is having left upper abdominal pain. Derek, walk me through your assessment of that left upper abdominal pain.
I know you're going to start on the opposite side, asking if the pain radiates. So you would
Okay.
start at. So you said the left upper. So you would start at the right lower.
Okay.
Work your way up to your right upper quadrant. and then you're always gonna palpate where they say the pain is last
Okay.
to see if there's anything rigid, distending, if you can feel free fluid.
Okay. Does everybody understand why he palpated that left upper last?
Because you want to see if
Radiating pain.
Or it could be an aneurysm.
Right. Well, we're comparing too, right? So that's where the pain is. We want to compare, make sure everything else is to that pain. And then you said something else too.
It's always important to always listen to the abdomen too,
Yes. Why are we listening to the abdomen?
to see if you can hear like a slushing sound. See if you can hear different organs working.
Back.
Okay.
Bowel sounds.
Bowel sounds, absolutely. So when you are palpating that area, how would you know that? So you're talking about rigidity. There was something else you said. You're cutting in and out, Derek. Rigidity, tenderness.
Right.
So what does that mean to you if the patient says that it's tender or that you feel rigidness?
Means that there could possibly be free fluid, or the organ is swollen
Okay.
from possibly an infection or trauma-based
Okay.
situation.
Right. So you have to remember, of course, we don't have x-ray vision. So our touch, our sensations when we're doing these type of assessments is our x-ray vision. That's why it's important to reassess these trauma patients. I can't remember what your book says, but I know typically North Carolina State says every 5 minutes, because we have to compare our initial assessment to our second. So if there's any swelling going on with this patient, we need to find out sooner rather than later, especially when we get things like bleeding in the right upper or left upper quadrants. You know, we've got that liver, we've got that spleen. We need to make sure that we are treating those aggressively if there's any swelling, because can we fix a lacerated liver in the field?
No.
No. So they're going to need what? What would your treatment for this patient be?
Oxygen, position of comfort, of course, for them. Depending on blood pressure, if they are bleeding into the abdomen, you want to keep the pressure above at least 90 systolic if you can, or at least as systolic as you can. No, I mean, of course, we have nothing that we can give for pain, but I mean, if we felt it was indicative, then we could always have a medic try to ease the pain as much as possible, but not mask the pain. Because I know some doctors will tear you a new one if you do mask the abdominal pain with pain medication.
Right. So where does this patient need to go?
Possibly a trauma center.
Yeah, possibly trauma center. We don't have those around here, do we?
No.
No.
Or if they're bad enough, to a local hospital to stabilize them.
Okay. All right, so what's in our right lower quadrant?
Appendix.
Appendix,
Large intestines.
and small intestine.
Okay.
Part of it.
How about our female patients?
Ovaries.
Okay.
Part of the uterus and cervix.
All right. So why is it important in a female to know, of course, we know typically where those are, but why is it important?
Because they could be possibly pregnant in the tubes.
Because every female in childbearing age is considered pregnant until proven otherwise. We don't carry pregnancy tests on the back of the truck. Seen them shows where people give birth 9 months pregnant and they don't even realize they're pregnant. So every patient is pregnant until otherwise proven. So when we think of our right lower quadrant or even our left lower quadrant pain, if you have a female patient who is in the childbearing age and she's having that right lower or left lower pain, she doesn't know when her last period was, she's not on birth control, what could be some possible factors of why she's feeling this pain?
She could have an ectopic pregnancy.
Okay, and what's an ectopic pregnancy?
Pregnancies in the tube area.
Okay. Can these be dangerous?
Yes.
Yeah, absolutely. So why are they dangerous?
Because the fetus is trying to develop and grow and attach up anywhere other than in the uterus and the stuff like that. So
Right. So yeah, so the egg is supposed to be implanted in the uterus, the fertilized egg. Sometimes that doesn't happen, and so it could be in the fallopian tubes. And so as this egg fetus grows larger and larger and larger, the fallopian tube cannot handle this. So what happens?
it could burst,
It bursts. And so what happens when it bursts?
bleeding, excessive amount of bleeding.
Yeah. So now what is our patient going into? Yeah, shock. Absolutely. So these patients definitely need treatment fast. How do you think that this patient, let's say you respond and the tube has burst already, how do you think this patient would present?
Pain in a fetal position.
Okay, so severe pain, yeah. Does it matter how far in gestation they were?
Yes.
Yeah, it does. Yeah, absolutely. So when we think about bleeding and blood loss, what do we look like? What do we think that their blood pressure and heart rate could be?
Heart rate up, blood pressure down.
All right, yeah. And then as they get further into that, what's going to happen to their heart rate?
It's gonna slowly trend down as well.
Yeah, it'll decrease. So how aggressive would we want to be with fluids on this patient?
Extremely.
Okay, so what would our first bolus be?
I would wouldn't you start off as with the bolus like 250, then
So the-
reassess, and then
the
titrate
bolus-
it back?
You can let's say that you'd set your bolus at 500. You could say I'll do 500, but at 250 I'll check. You know, I'll never disagree with that, because like our population is becoming more and more unhealthy at a younger and younger age. So we never know what underlying issues they have. They might not know what underlying issues they have. So it's never wrong to reassess your patient, because we don't want to give too much fluids. So we don't want to overload their circulatory system, their pulmonaries. We don't want to cause any difficulty breathing. So 500, but definitely you can check at 250. I do.
So for testing purposes, is it bolus that start at 500?
Yes.
Okay.
So I know y'all will actually probably do this in your lab, but does anybody actually know how to properly palpate, like hands-on?
Okay, so I know you take your right hand flat, and you take your left hand and go where your knuckles bend, and
Okay.
you slowly go like a upward, like kind of like a wave-like motion. That's what I was taught, because you don't want to put too much pressure with your
You don't.
fingertips.
You don't, but the goal is when we're pushing, because you still have to kind of give a firm pressure. I mean, everybody's anatomy, our makeup is different as far as our structures, height, weight. So some of us, we have to be a little bit more aggressive, and some, you know, we have those 98-pound old grannies who don't have anything. So of course it's different per patient, but remember, you're also It's tactile. That's what we're feeling. That's our x-ray vision, is our hands at this point. And so we have to be able to go in there and kind of feel. So this is another thing, you know, talking through your patient and saying, okay, I'm going to push here. Let me know, does any of this hurt? I'm going to push here. Let me know, does anything hurt? And watch their faces. Sometimes they might not tell you it hurts, but especially when you get that older generation they're not going to tell you things hurt, it'll show up on their face. So when you're palpating, we're feeling, we're looking for any signs of swelling, anything that feels like it shouldn't be there, anything that feels like it should be there. You know, those are things that we're making those mental notes of as we're doing our assessment. So when we go back to the guy who was in a motor vehicle accident, unrestrained driver, and he has possibly hit the steering wheel. Now, this is covering thoracic and abdominal. Walk me through what injuries you would think he would have and why.
So
Just given off of that.
So, say what you just said. Sorry. So he's an unrestrained driver.
Unrestrained driver who has impacted the steering wheel.
Okay, you're going to think of possibly a spinal injury and possibly seat, like in your cervical or thoracic cavity, part of the spinal column.
Okay.
Facial trauma, airway compromise, possibly a intracranial pressure change.
Okay.
Like I said, trauma to the mouth. You're gonna look for teeth, make sure the airway is open.
Okay.
What part of the body hit the steering wheel? Just the head?
His thoracic area.
So you're gonna look for free fluid in the abdomen,
Okay.
distension, rigid, any signs of shock, which even if you don't see it, doesn't mean it's not going on.
Okay.
Like we said, possibly a pneumothorax.
Okay.
If indeed he did hit at a high rate of speed. I think that's about it.
Yep. So
I can think of.
get in the habit of when, especially Demetra, do you do EMS? You do gates, right?
Yes, ma'am, I do EMS.
Okay. So everybody here has experience with EMS. I try to drill people's head before you get to that call. Start thinking of what could be going on with this patient. Of course, usually when we get there, sometimes it's nothing like we would have ever thought. But if you're starting to go ahead and form that treatment in your head of what could be going on, you're almost assessing that patient before you even touch them or make any eye contact. Because remember, we start treating and form a treatment plan on our signs and symptoms. If we're already getting those symptoms with our dispatch, you've already got one form of information. So if you get dispatched to an MVC 30-year-old male unrestrained driver, frontal impact with the steering wheel and airbags deploy, that right there, we already know that he's had some trauma to that anterior thoracic and possibly face region. So we know that the head, neck, and thoracic cavity, and of course our abdominal region too, could be involved in this. So we start thinking, okay, C-spine, precautions. We need to start looking at possible shock. We need to look at any type of injuries to the rib area, rib cages, our lungs, our heart even, and then start looking at like our liver and then our spleen and things like that. So working our way down is very, very important. But if we already can start to drill a plan in our head of what could be going on before we get there, it can definitely put you ahead of the game when you get there. I can't tell you how many times I've started spiking bags or looking something up in the protocol because I knew it was a call that I haven't been on a while because of those dispatch complaints, and then I knew what I was going to, and so I knew what I needed before I even got there. All right, So we talked about MVCs in our thoracic and our abdominal cavities. What are some other type of traumas that we can see that when we deal with those areas?
Falls.
Okay. So what kind of injuries will we see in our thoracic and abdominal areas with falls?
Basically all the same stuff as the MVCs, just because you're going to be falling at a uncontrolled speed.
Okay.
You're not going to be able to catch yourself, so therefore you're going to have pretty much the basics of what I just said on the same aspect.
Okay, so there's still traumas, but our mechanism of injury is different, right? One is, if we think of MVC, we think, it's full force, and then a fall is more, it might be uncontrolled, but hopefully if it's like from a standing position, their MOI might not be as significant as it was with an MVC. Then of course we have to look from like our falls greater than 10 or 15 feet, because then our MOI definitely increases with those. But age comes into play with those too, right? If you have a 4-year-old fall from a standing height versus an 80-year-old fall from a standing height, their injuries can be totally two different things, right?
Right.
Yeah.
All right, so what are some other traumatic injuries we can deal with?
Assaults.
Assaults, okay. So what kind of injuries do we see with assaults?
Facial trauma.
Okay.
9 out of 10. I mean,
Oops.
depending on the type of assault, I mean, you could have trauma to the thoracic cavity as well, whether it be
Okay.
they were hit by a bat, or they were stabbed or shot. And
Okay. So let's break those down. So let's say it was an assault with a bat, okay? What kind of force is that?
Blunt.
That's blunt. So what do we see with blunt force traumas?
Internal bleeding.
Internal bleeding, okay.
organ ruptures.
Organ ruptures. Yeah. Remember, no matter what that source of energy is coming, as soon as it hits us, that energy still travels. So yes, organ ruptures, absolutely. This is when we see more of that. We don't really see external as far as open wounds. We might see some broken ribs, but we see more of what the bruising, the redness, the swelling that associated with the blunt force traumas. So now we get into more of our trajectories with our stabs and our gunshots. So what are some special things we look at when we think of like stab wounds?
Do not remove the object that it was stabbed with.
Okay. When do we
If it's
remove
stuck in.
when do we remove the objects?
If it's obstructing the airway.
Absolutely. So what are some things you want to know about what they got stabbed with?
Is it rigid?
Okay.
Is it straight? How long it is?
Okay, very important. So knowing, like, so if it's a knife, the type of knife. Is this a butcher knife, a pocket knife? That's the only two knives I can think of. But, you know, that definitely comes into play with the type of injury we could have. How about where? Oh, yeah.
Oh, yeah.
And how many times? I'm not a crimeologist or anything, but when I think of stab wounds, I think of repetitive. So maybe they could be stabbed more than once. So identifying where those wounds are is very important. That takes place maybe in our rapid trauma when we're looking for any of those life threats. So let's say you have one in the thoracic area that is, there's no wound or there's no knife there. There is a wound, no exit, but it's bubbling. What could that be?
A sucking wound?
Okay, a sucking chest wound. All right, we know how to fix that, right? How do we fix that?
Occlusive dressing, right?
Occlusive dressing, absolutely. All right, so let's say that we are going on and everything's cool, it's gravy, we have controlled all of our hemorrhages, we've got our IVs, We've got them on oxygen. We're treating for shock. We're on the way to the hospital. We've got on capno because this is respiratory also, right? So we're doing everything we're supposed to do. We notice that his respiratory rate is dropping. He's complaining of difficulty breathing, and his O2 sat is dropping. What do we need to do?
Put him on oxygen.
He's on oxygen.
Oh,
And
and it's still dropping.
increase the flow rate if you can.
He's at 15 liters.
Oh, he should be on a normal breather.
Is he alert and conscious?
He is.
We can readjust
You
the
can
airway.
readjust the airway.
I mean, possibly CPAP if it gets to where his respiratory drive is completely diminished.
Think about what you treated him for. What did you do? What procedures?
There was
Well,
a-
then I'm going to get a medic to my location then because he might have a
Okay.
hemopneumothorax.
Okay. Remember, with those occlusive dressings, we don't want to cause any of that negative pressure. So although they have that vent sometimes, what do we have to check to make sure?
To make sure it's burping.
Yep, absolutely. So sometimes it can seal itself up. These wounds are what? They're bloody, right? So sometimes you have to clean it a little bit. So make sure if they start having any of those signs and symptoms, we go back and look at our equipment. We want to make sure that we are treating and reassessing anything we did. So it could be as simple as lifting that up and letting that air escape. We don't deal with sucking chest wounds a lot. They've come out with a lot of cool equipment for these. But honestly, you guys, you just need the simplest, I don't even know the word for it, seal that you can tape on 3 sides and you're good to go. They actually say that the occlusive dressings that come in those, what is it? The silver packs, they actually take the occlusive dressing out and throw it away and use the actual pack that it comes in to use it. So, I mean, be creative. If you don't have one, or if you have used what you have and you have to use more, make something up. You've got plenty of equipment in the back of your truck.
I've seen somebody use a glove.
Yeah, absolutely. Yeah, but don't forget, if your patient is starting to show some signs of respiratory distress, is to actually burp that wound. I know we covered in last class about like arterial bleeding, venous bleeding, and capillary bleeding. Don't forget, you can associate those with your thoracic and abdominal injuries as well when we think of like stabbing and gunshots. So gunshots, I think we talked about that a little bit last class too. Thoracic cavity, why are those dangerous?
Because you don't know what it hit.
You don't know what it hit. Bullets and hearts don't mix. Bullets and lungs don't mix. Bullets and tracheas don't mix. Bullets and anything in your thoracic and your abdominal cavity do not mix, okay? We were talking about 22s and why they're so dangerous. Dimitri, I think you answered it last class. Why are they dangerous?
Because they bounce around.
They do. They bounce around and they hit everything on the inside. So just because there's not an exit wound, don't think that your patient, there's not that much injury, or maybe it's not a gunshot. I mean, how many of y'all have went to a gunshot before that did not look like a gunshot?
Me, I had one stuck in like T4, T5. It
Wow.
went in and it stopped right there.
What was his complaints?
Back pain. He was
Back pain?
And then he said he started getting some numbness in his legs.
Did he know he was shot?
He did.
He did? Okay.
He said he felt like he said he felt his back get hot after he heard the gunshot.
Okay. So, of course, these are traumatic injuries, but like Derek just said, this is now a gunshot wound to now possibly a spinal injury. So make sure that when we're assessing and treating these traumatic patients, no matter what their chief complaint is, make sure that you check out their posterior, their cervical spine, everything, to make sure that we rule out any type of back injuries, because we don't want that to be underlining and we miss it. Because what's happening with these traumatic injury patients? How are they presenting? Are they just kind of like, man, I got shot?
No, most of the time they're critical.
Yeah, most of the time they're probably really excited So kind of same thing as like our fight or flight, our heart rate increases. We just kind of get really anxious. Kind of same thing here. They're not going to be like, man, I got shot. They're like, man, I got shot. What's going on? You know, help me, help me. So sometimes they're focusing on that, kind of like we're focusing on one thing, and they don't even see or feel or have a complaint of anything underlining until kind of their body kind of either, you know, calms down a little bit and they realize, hey, I do hurt here. So they might not even be aware that there's something else underlining going on with them as well. I feel like in the thoracic cavity, you know, most of it, of course, is going to be our cardiac and then our respiratory system. Are y'all pretty familiar? I mean, because we've got like 10 minutes left to cover a little bit if you have any questions on lung sounds, things that we shouldn't see when we hear heart tones and lung sounds. And if we are, how do we treat those or find out what's going on? I'm gonna take that as a yes.
Sorry, I was trying to think of like some questions or something. I have nothing.
Yeah, me too. I was thinking. I'm sorry.
No, you're fine. I was happy. And Cliff covered the head, neck, eyes, all that good stuff, nose.
Yeah.
What is one huge difference between the thoracic cavity and the abdominal cavity?
A huge difference.
A huge difference.
Is it the diaphragm? No. Huge difference.
One has a cage of bones, so
Oh.
nice, hard, protective around it, and one has nothing but skin.
Hmm.
So our rib cage, of course, is bones. So we look at that associated with the thoracic cavity versus the abdominal cavity does not have that. That doesn't mean that the thoracic cavity can withstand more trauma, because trauma can cause broken bones, which does not play well with lungs and hearts. But we do look at it differently because there's nothing there to protect anything in our abdominal area with our blunt force traumas and our traumatic as far as gunshots and penetrating traumas. Do you have any questions about thoracic or abdominal cavity? I think most of that y'all pretty much knew. It was just a review.
I was about to say a lot of that went back to the basics.
Right. Yeah. Our anatomy doesn't change. We have the same stuff, different places. Maybe, who knows, in a million years we won't have our gallbladders anymore. But everything's typically the same. I would say in our thoracic injuries, just associate yourself with lung sounds, because lung sounds, fluid in a thoracic injury doesn't, we think of fluid like edema and CHF. So in a traumatic injury with our thoracic cavity, it could be from something different, of course, from that trauma, but it could be something medical which caused that trauma. So make sure that we are listening and that we know how to treat them. Y'all have any questions?
I don't.
No, ma'am.
Cliff, I think we're good.